Welcome friend, brother, colleague of the medical career, medical consultant, it is a pleasure to greet you. In these occasions, I will talk to you about spontaneous abortion. I urge you to consult your medical guidebook about the subject so that you can find out more about it. I hope I can help you. Definition: spontaneous abortion is the loss of the fetus before the 20th week of gestation, calculated from the date of the lost menstrual period or by the birth of a fetus weighing less than 500 grams. It is important to say that early abortion occurs before the 12th week, while late abortion occurs after the week. It can also be classified as incomplete, full, threatened abortion, inevitable, deferred abort. Synonymous, as it is obvious, and everyone knows it as abortion, epidemiology, and demographics. Incidence: 15 to 20% of clinically recognized pregnancies, with 80% of abortions occurring in the first trimester. Risk factors: history of previous pregnancies, 1. Risk after a previous birth, 5% 2. Previous abortion, 20% risk in the next pregnancy. 3. Vaginal bleeding, especially more than 3 days, has a 15 to 20% chance of miscarriage. Genetics: distribution of abnormal karyotypes. Autosomal trisomy, 50%. Menosomy 45, X, 20%. Triploidy, 15%. Tetraploidy, 10%. Structural chromosomal abnormalities, 5%. With 2 or more spontaneous abortions, it should be assumed that there is a risk of spontaneous abortion in the studied pregnancy. Symptoms and signs: 1. Profuse bleeding accompanied by pain. 2. There may be cervical dilatation with a history or presence of fetal tissue. 3. Cases of delayed abortion, the uterine size may be less than that corresponding to the menstrual date, in contrast to male pregnancy, in which the size may be larger. Etiology and general terms: the etiology can be classified in terms of factors as maternal, environmental, fetal, genetic, being most of the spontaneous abortions related to genetic or chromosomal causes. Causes: uterine anomalies, incompetent cervix, submucosal erythemas, intrauterine adhesions or synechia, autoimmune diseases, uncontrolled diabetes mellitus, HLA association between father and mother, infections like TB, chlamydia, plasmodiarrhea, tobacco, alcohol, radiation and environmental toxins. Diagnosis: differential diagnosis, normal gestation, high diaphragm normal pregnancy, ectopic pregnancy, dysfunctional uterine bleeding, endometrial or cervical pathological lesions. Assessment: due to the potential maternal sequela, all patients with bleeding in the first trimester should be evaluated to rule out a possible ectopic pregnancy. The previous gestational history guides the assessment. Many of the treatments require preventive treatment, including diabetes management treatment. Lab test: type and antibody screening is used to assess the need for Rh immunoglobulin. In circumstances where an ectopic pregnancy is considered, serum quantitative HCG can be used in conjunction with transvaginal ultrasound to assign a risk level. During the conception period, HbA1c, anticardiolipine antibodies, lupus anticoagulant, karyotyping, progesterone levels can be studied. Imaging diagnosis. Transabdominal low transvaginal ultrasound can be used in conjunction with menstrual data and quantitative serum HCG to document the locations of the pregnancy. Put a lot of attention here: the presence of fetal heart, the size of the gestational sac, and associated pathology in embryo or fetus. In the treatment, we place 3 options of treatment. Non-pharmacological treatment that depend of condition of the patient, the desire to continue the pregnancy and certainty of the diagnostic. In the acute treatment, we say if the incomplete abortion between the 6th and 14th weeks can be associated with significant blood loss, so these patients should undergo D&C, Legard. In the chronic treatment, we say then waiting can be considered in the dose gestation more than 6 menstrual weeks, depending on the clinical situation and clinical situation and the patient's desire. Never forget this. If you want to read this, pause the video and read. Forecast. In most cases it is important to document the resolution of the pregnancy in terms of pathological samples from D&C or through reduction of quantitative HCG. If the anatomopathological report does not confirm an abortion or the quantitative HCG is maintained or elevated after evacuation, the diagnosis of ectopic or Miller pregnancy should be considered. Derivation. In cases of ectopic or delayed gestation, surgical evacuation of the uterus and possible laparoscopic evaluations should be performed by qualified personnel. In this clinical case, we have a 30-year-old female patient who came to the hospital because she tested positive for pregnancy. The strange thing was that the ultrasounds always came out negative, but the pregnancy test said positive. The doctor sent her to her house. The same patient returned but with jaundice, pain in the right hipocrum and weak. To X-ray you found this. We must not forget that if a pregnancy test is positive, we must do a physical study of the entire abdomen. In this case, the patient died due to an ectopic pregnancy with a fetus in the liver. Thank you very much. Our next topic is corneal abrasion. Do not forget to subscribe and leave your like. I upload videos every 2 days. Regards.